afternoon, guys. Sorry for being late, but I have this terrible headache from like 2 days, so probably worried. Thanks for coming today for the 8th Journal Club presentation. Today we have Gloria, or Tao-Yu.
No, just Gloria.
Gloria, okay.
Finally, 6 years.
Which is a 6-year classmate. And she will talk about blood GROUPS and RHESUS status, predictor for cardiac resynchronization therapy. So enjoy your presentation, and thank you, Gloria, for being here with us today.
So, good evening, everyone.
Good evening.
Well, it's a long day. After work, after lessons, after rotations, you are tired. Me too. You can tell by my voice. So, I'm also anxious. TED Talk told me, now it's better we have something interactive. So please, be nice, be kind. Do me a favor. Raise your hand. Raise your hand. Raise your hand, please. Okay, so people who doesn't know your blood type, put your hand down. So if you know your blood type, put your hands up. If you are rhesus positive, put your hand down. RH positive, put your hand down.
No, can we do it again?
Okay, everyone hands up. Okay, so if you don't know your blood type, put your hand down. If you are rhesus positive, which means RH positive, put your hand down. Okay, we find our targeted group today. So today I would like to present a paper about blood group and the RHESUS status as potential predictors of outcomes in patients with cardiac resynchronization therapy. I'm Tao-Yu, and I'm not doing anything related to cardiology, not my thesis, not my research. So if you have any doubt, it's okay to write me. Maybe I will tell you the correct answer. And this paper, I found this paper together with my tutor like early this year in January as a peer-to-peer review, as article revision. So this paper is not yet, it's just properly submitted to the journal. And I just asked the author for the authorization, Dr. Nikos Papageorgiou. He's now working in the Barts Heart Center in London. He has already published like more than 330 papers, and besides more than 5,000 times. He's also the member of the European Society of Cardiology and the Heart Failure Association. So let's go back to a little bit to the third year. Heart failure. Heart failure is characterized by symptomatic left ventricular dysfunction due to the structural or functional impairment of the ventricles. So it's affecting more than like 60 million of the population worldwide. So let's take US for example. It costs like 1 million hospitalization and costs like more than 30 billion US dollar annually as a medical expenditure. And the most important thing is that the first year mortality rate is up to 20 to 25%. For heart failures, it depends on the anatomy. So the situation happens on the left ventricular. Patients may have like short of breath, dyspnea, pleural edema, pleural effusion, and cyanosis. If it's on the right ventricular, you may have a systemic edema, for example, inferior limbs, legs, edema especially, nocturia, hepatomegaly. The New York Heart Association classification of heart failure classified the patient by the symptoms into 4 different classifications. The class 1, there's no limitation for the physical activity. For example, a patient can do everything, whatever they want. The second group, the patients can do like slightly like physical activity. For example, they can do some sports, they can go swimming, they can go jogging, but it doesn't mean that they can play in NBA or they can do scuba diving. The class 3, The patients still can have a normal life. For example, they can go to the supermarket, buy some food, and cook a dinner for themselves, but they cannot do any sports. And the class 4, for the patients, just stay in the bed. And another important parameter for heart failure is the left ventricular ejection fraction. So for the LVEF, like over 50, which will have like a heart failure with a preserved ejection fraction, which HFpEF here. So this will cause like stiffness of the heart muscles on the left ventricular, usually due to obesity, diabetes, pericardial disease, chronic disease, chronic kidney disease. For the patients like suffering from ischemic heart disease, inflammatory damage, or toxicity, will cause like a weakening of the heart muscle of the left ventricular. This will cause like the LVEF like lower than 40. So, general management for heart failure, you can have a lifestyle change. So stay in bed, don't do any sports, don't do something active. Or we can hospitalize the patient with properly the oxygen supply, or we can do together with the routine hemogas checking. Intervention included, for example, ICD or CRT implantation, and pharmacological. As we all know, AC inhibitor, ARB, beta blocker, diuretics, especially aldosterone antagonists, and some new drugs, for example, SGLT2, and a combination of ARB9. This is especially for the patients with RBBB. So, as a title of the article, we need to know more about CRT. Let's talk about CRT. I hope you are still awake. So let's talk about the second important role in this article, blood type. So as you all remember, first year, genetics. Hope so. Hope you all passed it. So we now know that the blood type group is considered as a related variation on the chromosome. So for the ABO group, it's counting on the chromosome 9. So in the situation, we have like type A, type B, type AB, and type O. And the other type is a rhesus factor. Generally, we have like RHD and RCE. Don't worry, I'm not going through it. Okay, nothing genetic today.
I have a question on the answer. Just joking.
I love you, okay? Love you. So after this, why is so important? What is the relationship between heart failure and the blood type? An article published like 3 years ago genetically determined ABO blood group and its association with health and disease. This paper indicated that up to 140 loci is accounting for the heart atrial fibrillation, and only 11 accounting for the heart failure. But so far, up to now, to date, to this moment, there is no strong evidence. There's no article showing the relationship between the blood group and the heart failure. So that's why we have this article. This is a retrospective, single-center, observational, long-term follow-up. The mean of the follow-up years at 4.6 is actually down like up to like 12 or 14 years. 499 patients with successful CRT implantation in this center was included into the research, in which 226 of them are with the O type, 273 of them are with non-O type, which means A, B, and AB. We are now counting for like MNP group or the Bombay blood type. For the rhesus factor, rhesus positive, we have like 423 patients here, and for rhesus negative, we have 76 patients here. The inclusion criteria of this paper is according to the New York Heart Association classification, 2nd to the 4th. And the symptomatic patients, even though they are undergoing a good drug therapy, LVEF under 35, QRS0 more than 120. The exclusion criteria is that the patient is in need of the IV inotropic drug therapy, or the patient's life expectancy is lower than a year, not only for the cardiopathy, also due to the other kind of comorbidities. At the end of research, 262 patients are dead, and the other 14 are underwent transplantation or fitted with an LVAD. So, what is our result? The result shows that for the O group and non-O group, there is no significant difference on the survival rate after a long-term follow-up. But the group of like rhesus factor, rhesus positive, and rhesus negative, we can see that from here. After 10 years, 12 years follow-up, the rhesus negative group shows a better survival rate. So when we think about mutation, as we said, mutation as a blood type, blood type is considered as a kind of mutation. What kind of therapy should we do on it? Targeted, genetic. Do you all agree? Yeah. Okay. So we have the monoclonal antibody and the polyclonal antibody. These 4 different drugs, they are still in trial, which is not in the market, and they are targeting only the RHD factors. As I just mentioned, not so important, but you need to know there are 2 different groups. They also did like the ischemic and non-ischemic comparison for the rhesus factor, like negative and positive, and it shows no significant difference. Rh negative groups was associated with better survival in heart failure patients with CRT. Further research into rhesus association pathway and related drugs, no matter there is a cardiac signal or not, is required. This is the conclusion of the paper. But my question is here. Why am I presenting this paper? As I mentioned, I'm not doing anything related to cardiology. I'm not doing my thesis. I'm not doing research. And even didn't get to the enrolled in cardiology exam. Why am I doing this? Because today I would like to present a concept. I want to bring up with all a concept that, for example, as before in the course when we were doing one of the presentation, we talk about prostate cancer. The prostate cancer nowadays, we are talking about like when we need to confirm the prostate cancer, we have a really brand new, specific, extremely only for prostate cancer. It's called NPMRI. So if we indicate the patient to do the NPMRI as a confirmatory diagnosis, and the patient just come back to us, hey doc, I didn't do the exam because this is blah 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 blah. I don't know MRI. It's not covered by my insurance. Is that what we are looking for? Is that what we want in the future? I don't think so. So today I'm presenting this article.
Thank you for your reminding.
So today I'm presenting these articles because, just as I said, as a title, heart failure is something really fatal, really severe. But what's the relation with something like really simple, as we can know, like we can tell your characteristic even from your ABO title of the group. An article published last year, BMI and HbA1c are the metabolic markers for pancreatic cancer. So we're trying to use something like really easy, not so fancy, really easy, something we already have as a BMI, easier for the patient to understand. They even have it on their scale at home. HbA1c, you can even buy the machine just in a pharmacist. Also, another paper just published 2 weeks ago. Free living core body temperature monitoring using a wrist-worn sensor after COVID-19 booster vaccination. This is not only applied for the COVID-19, but also for the other kind of disease like temperature-related disease. Something easier using, easier accepted by the patient. So what I'm going to tell today, why I'm choosing this paper as an example, is that in the future, I'm asking you guys, also myself, future doctors, some doctors were there, professors. When we think about like diagnosing a new kind of disease, or maybe we try to create a new combination of the therapy, or maybe we try to modify the criteria for the classification. Of course, we have to think of something new. We need to create something new. But why not we just give a glance backward to something we already have in hand? Something like easier, old school, easier, but less costly, and better, properly accepted by the public. Let's make a complicated word easier. Thank you very much.